warm welcome to you all. Today there will be a discussion on rheumatology. We have two presenters and two mentors and two experts who are very conversant and very expert in their field. Professor Rakesh Kumar Mondal, Professor of Pediatrics in Medical College, Kolkata, and Dr. Suparna Hajara. She is also professor in the Vivekananda Institute of Medical Science. I welcome you all, and I welcome all the participants. And now I'll hand over to the platform to Dr. Swapun Roy, Scientific Chairperson of the session.
Thank you, Madam. It is the another Sandhya Pathshala organized by West Bengal Academy of Pediatrics. And today there will be case presentations by Dr. Amrita Rai and Dr. Paipi. So, and the mentors are Dr. Jigna Bhatia and Dr. Abhishek Dadas. So, I will hand over the podium to Jigna to conduct the session. Over to you, Jigna. Jigna, are you there?
Yes, sir. Thank you, sir, for inviting us all for this Pathshala today. And I would like to hand over to my the PG, who's the second year PGT at ICH. He's Swangyang Mang 5P, and he will be presenting the first case. Mang, would you like to share your PPT?
Yes, ma'am.
And welcome, Professor Joydev Rai over here. Professor Rai is also there.
Thank you.
Can I start, sir? Hello.
Slide show mode. Go in the slide.
Can you?
Slide show mode.
Can I start, sir?
Yes, right. Absolutely.
Just a minute. Yeah. Good evening, everyone. I am Dr. Sandhya Mang 5P. I'm second year PGT from Institute of Child Health. Coming to my case, child X, 14-year-old girl, hailing from Kolkata, informant mother, reliability fair, was admitted on 20th of this month, and date of examination was done on 21st of this month. And the date of birth is 21st of February 2009. The child presented with complaint of pain over bilateral ankle and knees since 26th of January this year, as well as swelling over the bilateral ankle as well as knees since the same day. Coming to the history of present illness, child was apparently asymptomatic till 25th of January, when she started complaining of pain over the bilateral ankle, which was insidious in onset, gradually progressive. Pain was initially in the ankle, which later on involved the bilateral knee as well as the dorsum of the foot. The pain is more in severity during the morning hours, and there was also associated stiffness with it. The pain decreases after 15 to 20 minutes of activity. And patient also complains of difficulty while walking as well as even standing also. And pain was aggravated on prolonged resting, and pain got relieved on movement. The child at the same time complained of swelling over the bilateral ankle joints. Swelling also was insidious in onset and gradually progressive. Swelling initially present over the bilateral ankle and dorsum of the foot. And this swelling later involves the bilateral ankle also. There was associated redness over the skin of the swelling, and patient also complained of warmth over the ankles as well as the knees. And the child was taken to a pediatrician, and the child was started on steroids and weekly dose of methotrexate and folic acid. And there was initial improvement of symptoms, but after decreasing the dose of the medication, the pain started recurring again. So after investigation, the child was advised for admission. There was no history of waking up from pain at night. There was no history of burning micturition. There was no history of cough, cold, or fever which precedes the illness. There was no history of contact with TB. No history of psoriasis in the family. No history of altered bowel habits. no history of rash, or no history of any pain abdomen. Coming to the past history, patient also had similar complaints in 2019, which lasted for about 8-10 days, and the child was admitted for the same complaint. And child was diagnosed as a case of reactive arthritis, and child responded to steroids and NSAIDs. Child was symptomatically better and was discharged, and there was improvement, and child was asymptomatic till the present episode of January 2023. Coming to the antenatal history, child primary uneventful pregnancy. There was no history of abortion or stillbirths. Mother was immunized, and there was no history of any disease or infection during pregnancy. Birth history and neonatal history. First order birth, term delivery. The baby was around 2.35 kgs, delivered by LSCS. Child cried immediately after birth. There was no significant neonatal history. All developmental milestones were attained as per peers. There was no history of regression of any milestone. Currently, the child is studying in 9th grade. Dietary and vaccination history. Child was exclusively breastfed for the first 6 months of life, meaning started after 6 months. There was dietary history taken by 24 hours recall method. The protein and calorie calculation was done, which was appropriate for age and sex. And immunization was complete as per NIS. Family history, coming on to the family history, there was no history of any consanguinity. There is history of diabetes and hypertension in the family, but there was no history of similar illness of the child in the family. Socioeconomic history, the family belonged to lower middle class as per modified Kukuswamy scale. There was no history of any allergy. There was no history of any contact with TB. Bowel and bladder habits were normal. Coming on to the examination, patient is sitting on the bed with a cannula in situ in the right dorsum. She is sitting with knees in a semi-flex position, and she looks healthy. On general head-to-toe survey examination, there seems to be some obvious swelling in both the ankles. There are silver striae in both the axillary folds. Child also looks a bit cushingoid with moon faces. On general examination, there is no pallor, cyanosis, clubbing, or edema. Lymph nodes are palpable. Neck veins not engorged.
Well, Dr. Happy, just
Yes.
wait. The experts, if you want to ask any questions on the basis of history, then you will proceed to the examination part.
Okay, ma'am.
So I request Dr. Rakesh and Dr. Suparna, please comment or ask if you want to have any queries and on the
So you
basis of your
said
history.
that if I am permitted to give the comment, madam.
Yes, sir.
Yes, sure. Ask the history,
patient
any
was-
points in the history you want to know, anything on anything
yes.
modification.
Initially, you told that patient was admitted as a case of reactive arthritis earlier, 2019, isn't it?
Yes, sir.
And you have put on NSAID and some minimum treatment, as I noticed.
Yes, sir. Yes, sir.
Then you noticed pushing white faces on examination or in the early part of examination.
Yes, sir. Yes, sir.
You said pushing white. How come this be possible? What are the history you have taken for that?
Sir, I have taken the history of steroid. How long has it been taken for? The parents told me that the child was put on steroid for tapering dose of steroid for around 2 to 3 months, sir. Because of that, I think the cushingoid phase is appeared.
That was given by you, or that was given earlier by somebody?
Sir, that was given by the parents. It was not given by. It was given by the treating physician, sir. Actually, the child was admitted in 2019. So after that, the child was put on steroid. So child was gradually tapered down on steroid.
2019 to 2023, 4 years. Even if you give for 2 months of steroid for 2 months, 2 months of
Yes.
steroid in the last 4 years, I don't think the patient will have pushing white faces.
Sir, after that, since the same complaint in January, the child showed again to the pediatrician, sir. That time
Okay.
also, the child was started on steroid as well as methotrexate, sir.
What was the indication there? Why you were started? What was the provisional diagnosis there?
Sir, we're thinking of some juvenile idiopathic arthritis, JIA.
So he was given earlier by somebody, isn't it?
Yes, sir. Yes, sir.
That is one point you have to mention.
May I ask a question?
Madam.
So from 2019, diagnosed reactive arthritis, put on short course of steroids, NSAIDs, child became well for 5 years. Again, 2023 January, put on steroids, for which developed, maybe at a high dose, developed Cushingoid faces. Fine. So was there any history of fever associated with
No,
this?
no,
You have
ma'am.
not
There was no.
mentioned anything about the fever.
Ma'am,
January, no history of fever. Oh,
I have
no
mentioned in
history
the
of
negative
rash.
history, ma'am. There was no
Okay,
history of
no.
fever.
Okay, no history of fever, no history of rash.
Yes, sir.
Okay, fine.
And what was the family history?
Family history.
And one more thing, is there back pain, anything low back pain? No history of low back pain, nothing joint affection, isn't it? No small
Yes.
joint affection history also.
Yes, ma'am. Yes, ma'am.
So whenever you have put on history, no history of this, that, no history of this, that is not, I don't think is the right way of approaching. You have to be relevant even on negative history also. If you have been reactive earlier, you should have taken specifically whether the parent have anybody HLA B27 positivity earlier or any bowel problem. And you have to be little more, I think, specific. Otherwise, you go on saying negative this, negative that, negative. This is won't help you, I think.
Yes, sir.
Absolutely, I agree with Dr. Rakesh. You have to be specific for the case. Cyanosis, etc. You have to be specific regarding this case. Family history, any history of contact with tuberculosis, any history of suggestive of GI or genitourinary involvement. Those
Yes.
things you have to lay more stress on. Okay.
Yes, ma'am. Yes, ma'am.
Ma'am, ma'am, can you
Because the
go to
child
the, ma'am?
Yes, yes. Yes.
And any history of axial joints. That's very important. Axial
Yeah,
joints
that's
and
what
the
I asked, madam. That's why I asked that any history of low back pain, no history.
axial joints involvement is very important.
When you are presenting a polyarticular case, you have to be very specific whether there is any systemic symptoms, yes, no, and polyarticular, whether peripheral or axial. Those things you have to mention. These are the two important things when you mention about about any joint pain. Peripheral, axial, systemic, present, yes or no. Okay, and any history of contact.
Yes, ma'am.
And any history of preceding genitourinary or gastrointestinal. Yes, Jigna, you wanted to say something?
Ma'am, I think most of it was covered in the negative history, excepting the axial. I think axial point what was missed out. Most of the relevant history.
Okay, no issue. Only for the learning we are doing all those.
Yes,
Yeah,
sir.
yeah.
Yes, sir.
The learning process we are also.
Axial you should mention, yes.
Yes, axial is missed out. Yes, ma'am.
And one thing I just want to point out, if you said initially it was reactive, it was diagnosed in some institute, some consultant have already seen it.
Yes,
Now
sir.
you are saying it's GIE. Whether you are telling two morphology. So whether there is any link between these two, or this is GIA and that is reactive, though reactive may be a part of miscellaneous other part. Even then the child is having polymorphic presentation. Initial one presentation, now this presentation. So do we have to see whether it's a new thing or it is related to past event or
Yes,
something
sir.
else? You have to, I think, keep that in mind also.
Yes, sir. Yes.
And yeah, one more thing, Dr. Rakesh has mentioned earlier.
Suparna, your net is poor.
That only taking 2 months of steroid. I don't know what dose she took. Maybe the child.
No.
Okay, madam, you can't hear? Can you hear? Hello, can you hear?
Suparna, your net is very poor. The voice is
Can you
breaking.
hear? Can you hear? Can you hear me? Can you hear me?
Yes, ma'am. Yes, sir.
Voice is breaking. Okay, I'll shift to another. So one thing I just wanted to say that in between these are medicines for any joint pain, or she was absolutely well.
Yes, that is important.
Because that is very important. You know what these children do, or what the parents do, is that they know that the steroid will give them relief, which the child had taken previously. We have come across many such cases.
Yes,
They
ma'am.
know that the steroid is the magic medicine. They have some joint pain, they go to the medicine shop and they prescribe themselves over the counter. So the Cushingoid phases must have been the child was suffering. I don't know. Jigna may be able to elaborate
Yes,
on that.
I think so. He might be symptomatic in between also.
Yeah, absolutely. Because this Cushingoid will not be explained by just 2 months of a dose of steroid in 0.5 or 1 milligram per kg. Difficult to explain, isn't it?
Yes, ma'am.
Yes.
Actually, the mother told me that they just stopped steroid after 2-3 months after 2019, after admission in 2019. But
You have to be very specific, regarding the history. These people actually, they hide
Yes.
facts and all. So you have to be very, very
yes, yes,
careful when taking history. Okay, continue.
yes. Okay. Coming on to the examination, vitals pulse is around 98 per minute, pulse volume normal, regular, no radio-radial delay, no radio-femoral delay, and no special characteristic of the arterial wall. BP in the right upper limb is 108/65, with 90th centile for height and age. 95th centile is around 125/78.
পার্টিসিপেন্ট আছে ইংলিশে বলুক সবাই বাইরে
Respiratory rate is 24 per minute. SpO2 is around 98% in room air, and temperature in the axilla is 98.4 degrees Fahrenheit.
শুনতে পাচ্ছেন না তো আমারটা
শুনতে পেয়েছে শুনতে পেয়েছে
Anthropometry, weight is 57 kgs, height is 152.5 centimeter, BMI is around 24.5, and SMR is stage 2. Coming on to the musculoskeletal examination, I'm doing the examination as per the PGALS, pediatric gait, arm length, and spine examination. First, I asked the screening question like, do you have pain, stiffness in any joint, muscle, or back? So there was pain in both the knees, ankles, and the foot. And do you have difficulty in getting yourself dressed without help? She had difficulty in putting on her pants, but no difficulty in putting on her t-shirts or dress. And does the child have any difficulty while getting up or down? The child complained that there's pain in the knees and ankle, which make it difficult to use the stairs. Biggest examination was done by examining the child from the front, back, and side. Since the child was an adolescent girl, I could not expose the child totally. So I did not expose the child. I made the child walk first on heels and tiptoes. The child could walk normally on heels, but while on tiptoes, the child had pain and difficulty. And the child was made to hold out her hands straight in the front. And the child was made to turn the hand over and make a fist. There was no problem in those two. The child was made to do pinch the index finger with the thumb and the other tips of the fingers. The child had no problem in that. And I squeezed the metacarpophalangeal joint. There was no tenderness. And I made the child do a namaste prayer sign, and after that, hand together back to back. But there was no issue or no problem in doing all this examination. And after that, I told the child to raise her, to put her shoulder, put her ear to the shoulder. There was no pain or no restriction of movement in that. And I told the child to lift her arms and extend the neck. The child had no problem in doing all this test. And I told the child to put her 3 fingers in her mouth, which she can do easily. And to examine the spine, I told the child to bend forward. There was no pain while bending forward. As you can see over here in the first image, I told the child to put the arm in front and to make a fist and to do all this thumb and index finger. And I told the child to lift up her arm and to put the arm behind the head and extend the neck. There was no pain in those examination. And I made the child bend down. The child had no problem in bending down. The only problem that the child faced in this is the child had difficulty while walking tiptoe. Coming on to the supine joint examination. First, look, the child is examined in supine position. There seems to be some obvious swelling in the bilateral ankle as well as the knees. and over the metatarsal joint. There was no erythema over the overlying skin and no scar mark seen. In feeling, the child is examined, both knees are exposed, right knee. There is no local rise of temperature. Patellar tap positive for effusion. Cross fluctuation is also present. In the left knee also, there is no local rise of temperature. Patellar tap positive for effusion. Cross fluctuation present, and crepitus also felt. And right ankle, there is no local rise of temperature, and cross fluctuation is present. And as well as in the left ankle, no local rise of temperature, but cross fluctuation is present, as well as tenderness is present in all this examination. On movement, first active movement, the child was made to do active flexion of the knees, but the child had difficulty in doing flexion, which is more prevalent in the left side more than the right side. And in passive flexion, there was restriction of flexion in both the left as well as the right. And there was crepitus also, which is felt. And in the ankle, the patient was asked to perform active dorsiflexion and plantar flexion. The child had restriction of movement, left more than the right, as well as in inversion and eversion also. And in passive movement, the child also had the same complaint of restriction of movement and pain while performing the dorsiflexion, plantar flexion, inversion, and eversion of the ankles. The other systems, abdomen was soft. There was no tenderness, no organomegaly. There was no.
Can I summarize your joint involvement examination?
Joint involvement examination mainly, sir. The disease mainly affected the lower limb more than the upper limb, and there was swelling and pain over the bilateral ankle as well as the knees, and there is restriction of movement as well as pain, and there's restriction of movement as well as pain in both the bilateral ankle as well as the knees.
Now, is it only small joint or large joint? Is it symmetric? Is it asymmetric?
Mainly involved the large joint, and like just the metatarsal joint also was involved. Sir.
May I add something?
Yes, ma'am.
See, when you're doing a PGALS, after PGALS is a screening technique, okay?
Yes,
so
ma'am.
after you perform a PGALS, you should be able to tell us which extremity you are thinking of. You have not mentioned anything, whether it's upper extremity, lower extremity, whether it's axial skeleton, whether it's large joint. Screening is a technique by which you have a rough idea that this portion is involved. Then after that, you go with the thorough examination. And from what your musculoskeletal examination, I can see there is chronic synovitis of bilateral, isn't it? Bilateral knee joint and ankle joint, you are having chronic synovitis because you have got crepitus.
Yes, ma'am.
Volume of the joint is increased, you have got crepitus. So there is chronic synovitis along with some restriction of movement, and there is no involvement of any small joints or axial.
Yes, ma'am. No involvement of any. Yes, ma'am.
And it is not symmetrical. Some amount of asymmetry. Some is more, some is less. Or it is usually symmetrical.
Yes.
Some asymmetry is there.
Some asymmetry is there, more on the left side, sir.
Yes.
On the right side.
Yes.
So there is asymmetrical polyarticular joint involvement, isn't it? Large joints.
Yes, ma'am.
No axial involvement.
No axial involvement. Can I continue, ma'am?
Yes, yes.
Respiratory system, there is bilateral air entry present, which is equal. There is no adventitious sound.
And one more thing, one question was put on in the chat box that somebody was asking about enthesitis. Very, very important because your previous part was the reactive arthritis. So when you were examining this patient at this point of time, you must say whether there is any enthesitis there or not. Enthesitis, tendinitis, bursitis. You have to mention all those points also because initially the patient started with reactive arthritis 2019. So you have to see if there is a link between these two or not, isn't it? You have to be careful.
Yes, sir. Yes, sir.
Continue.
Okay, so CVS S1 S2 heart, no S3 S4 or no murmur. CNS higher mental function and speech normal. Coming on to the summary, a 14-year-old girl residing at Kolkata presented with complaint of pain and swelling of both knees and ankle joint, along with swelling over the metatarsal joint since January of this year. The pain was more in the morning on getting up and subsided within 15 minutes. The pain was also more during rest and subsided on exertion. There is no history of fever, nocturnal pain, burning micturition, loose stool. There's no family history of similar illness, no history of contact with tuberculosis, no history of any back pain. On examination, there was difficulty on walking on tiptoes in girls, and there was pain, swelling, and restriction of movements of both knees and ankles. There was also swelling over the metatarsal joint of both the legs. Therefore, according to the history and examination, I've come to a differential of polyarticular juvenile idiopathic arthritis.
Can I make a point?
Yes, sir.
Why are you stressing too much of tuberculosis? Tuberculosis doesn't cause actually polyarticular involvement.
No, Dr. Mandal, I think history of tuberculosis is important because they might need the treatment with a
Polyarticular dactylitis.
not because the joint tuberculosis history is important, not because of the involvement of the joint, but
Yes.
because of the treatment point of view.
Yes.
But I would like to add one thing. You must mention the negative point also in the summary without
Yes,
any systemic involvement. Polyarticular J, next line is there, but you have mentioned all the findings without any involvement of the eyes or organomegaly or rash.
Yes.
The systemic
Okay,
involvement, without any, one line should be added in the summary.
Yes, ma'am.
Okay, continue. Continue, Dr. Mandal.
Yes, eye involvement should also be thought of and has to be told properly.
Okay, sir.
Next.
Differentials like SLE.
Can I ask you one question?
Yes, sir.
How come SLE is differential diagnosis here?
Points in favor and points in against. Just tell me.
Sir, points in favor of SLE. Points against SLE will be there's no history of any skin manifestation or no history of
No,
any.
you kept when
SLE,
it is a differential
SLE, does it
diagnosis.
cause deformity or deformed arthritis? Does it cause chronic arthritis? SLE, does it cause?
Yes, sir.
What are the points in favor of SLE first? Then you say what are the against SLE. Why did you keep it in a differential diagnosis? There must be some points in your mind, na? I think Jigna, can you highlight something?
Yes, I think this slide was my addition because I'll just summarize the case because ma'am asked. So, ma'am, can I finish the summary after you all have cross questioned? Then maybe I can just sum it up later on.
Okay. Yes.
Okay.
So I just missed what was the provisional diagnosis, or he went to a differential, isn't it?
Provisional, I'm coming polyarticular JIS, ma'am.
Okay.
Do you have
And one more thing, Dr. 5P, you have not mentioned about response to anti-inflammatory drugs. The child was suffering from January, no? Well, he had a morning stiffness, and gradually as the day progressed, the pain, etc., decreased with activity. What was the response to anti-inflammatory medications like NSAIDs or not? She must have taken this. What was the response? Because the pain is an inflammatory nature, isn't it?
Yes, ma'am. Initially, the child was responding to NSAIDs, ma'am, and anti-inflammatory drugs, but later on, even that response has decreased, ma'am.
Okay. Fine.
And if suppose some patient have a typical diagnosis, it is not that you require to put some differential if it is not at all ready for that, isn't it? Because this patient is having chronic arthritis and some polyarticular things. It's not an acute thing, no non-deforming. I don't think it must be an important.
Exactly. See, SLE should not be kept here because this is a deforming arthritis.
Yes, ma'am.
SLE usually does not has a deforming arthritis. Okay. There is some arthralgia, there is some joint pain, there is some
Yes.
also arthritis, but it's not deforming, as Dr. Rakesh has mentioned. So
Yes, ma'am.
SLE, I think, should not come in this differential. Basically, it's a polyarticular JIA which has shown poor response to your anti-inflammatory drugs which she was using.
Yes, ma'am.
SLE, I think, should not come. There's no history of fever. There is no history of.
Rash.
The most point important against is a deforming arthritis. SLE should not come here, I think. What isn't it, Dr. Rakesh? Don't you think so?
Yes, yes, yes.
Hmm.
Yes, you can say it's some form of GIA, because GIA have classification also. They have different categories. You can some form of GIA. You can go
Yes.
on that line only,
Okay, sir.
or rather sometimes PSRA one form. If you say that was
Hmm.
also a reactive thing, something like post-streptococcal, that can also recur sometimes and persist for a long time. If at all in distant differential, I don't think lupus would be differential.
Basically, it's a polyarticular. By the anatomical distribution, it's a polyarticular GIA.
Yes,
It is a
ma'am.
polyarticular GIA which has got poor response, shown poor response to anti-inflammatory and has to be investigated.
And Dr. Shuparna, if at all they want to keep it to SLE in the end, and they might say there is no features of deforming arthritis, so it is less likely.
Yes, madam.
As there is a
SLE
history,
in
chronic
this
history,
case, yeah.
older girl child, older age, so I have kept it. But because of the non-deforming variety, I just ruled out.
Yes.
That could be the one explanation, and it should be in the end. I mean, bottom of the list.
If it is at all lupus, there should be overlap between lupus and GIA. That is
And
called
GIA,
lupus.
absolutely.
Otherwise, it won't be.
Yes, sir. Yes, sir.
Very, very difficult just to say about SLE in this case.
Yes, ma'am. Yes, ma'am. Can I continue, ma'am?
Yes. Some investigations you must have done.
Sir, investigation we have suggested, ma'am, like complete blood count, ESR, CRP, liver function test, eye examination. Ma'am, we have done the investigation, but I have not put the investigation reports in this presentation. Like, since I was told that it's more or less like an exam.
Yes.
Okay, if you remember, if you're not say what was the result, otherwise okay.
So what is your complete diagnosis?
Sir, according to the system of joint involvement, it more or less looks like a polyarticular JIA. Sir.
Do you stop here?
No, sir. We
polyarticular JIA, RF positive or RF negative?
RF negative, sir. Like
you have to be, that is the standard things in that's for the category of JIA, as per ILR.
Yes, sir. Yes, sir.
See, rheumatoid factor, okay, you have to investigate, but still going from the history, an adolescent girl, deforming arthritis, poor response to NSAIDs, the child may also be rheumatoid factor positive. You don't know.
Yes, ma'am. Ma'am, we have done the rheumatoid factor, it's negative.
Okay. And what about the other tests? Do you remember?
Just I have the report on my phone.
As far as clinically till now.
Okay, you see your investigation and can tell. You see your phone, take the investigation. Give him time.
Okay.
Ma'am,
so just
to
comment.
Okay.
Yes, on January 26th, the child was investigated. There was HLA-B27 negative. Count was 13,800. Neutrophil of 80, neutrophilic, hemoglobin was 9.9, ESR was 25, and CRP was around 359. And there was no ALT and AST were 165 and 152. Albumin was 3.6, bilirubin was 0.43. And rheumatoid factor was negative. And while on admission, the child total count was 10,080, neutrophil of 59 and lymphocytes of 35, hemoglobin of around 9.3, and CRP was 28.6. And the ALT and AST were 76 and 34. And bilirubin was 0.42, and total protein was 6.3, and albumin was 3.4.
What was the ESR on admission?
ESR on admission
was
less 25, he said.
No, ma'am, that was on January.
CRP.
That was in January.
Dr. Suparna, just explain for the sake of residents, or Dr. Mondal also, Rakesh, what is the difference in ASR and high CRP? Here the ASR is not raised, but CRP is raised. What is the importance of that? If CRP is not raised, ASR, what is the importance of that, especially in this matter?
So
All those things, sir, just for the sake of the residents. Sir.
okay, these types of inflammatory state, when it is non-infective inflammatory state, you expect a rise in the inflammatory markers. Both CRP and ESR should rise simultaneously, isn't it?
Yes.
But suppose you are seeing a very high CRP in the background of a low ESR.
Then mass
Okay.
maybe.
So
Yes.
you must think of a cytokine storm going on, which in
Yes.
this case would be called as a mass in a background of rheumatological disorder. What about
Yes.
the platelets were normal, isn't it?
Ma'am, platelet
Child
count was normal, yes, ma'am.
So the child was receiving steroids also at a dose of what when she came to you?
2 mg per kg, ma'am.
2 mg per kg.
No, ma'am, sorry.
Quite
Just 2 mg per kg per day, ma'am.
And that
So
was
that
steroid.
40 mg, ma'am. 40 mg.
40 mg steroids and methotrexate 15 milligram subcut.
Ma'am, oral.
Oral, okay.
If you are giving 2 mg per kg, if the patient required 2 mg per kg of steroid, then I think there should be some amount of systemic symptom without steroid. So you are probably not getting systemic symptom one because you are giving too much of steroid. You are giving 2 milligram per kg. It's a quite good dose. So
See,
be careful whether this.
Yeah, so this picture now, what is that your ESR, CRP are all on the lower side, isn't it? There's no transaminitis or complete blood count is also more or less normal, but the child is getting an adequate dose of anti-inflammatory medication,
Yes.
2 mg per kg steroid along with that 15 mg methotrexate, be it orally. So you have to think that why is the child not responding in the background of normal inflammatory markers? This case actually warrants a biopsy now, that why is the child not responding? You have given adequate anti-inflammatory medications.
Yes, ma'am.
And your inflammatory markers are also not that high. If your inflammatory markers were also very high, then we would have understood that the child is not responding. We have to step up higher. But since the child is having a more or less normal inflammatory markers, so these are the cases when you have to go for a biopsy of one of the joints, a synovial biopsy. What did you do? I don't know. What did you do, Jigna?
Ma'am, can I summarize the case now?
Yeah.
Ma'am, so this child had come to us initially in 2019. What Dr. Mang forgot was that there was a history of fever and joint involvement, but for a very short duration, which was not helping us classify it as GIA at that time, maybe just 10 or 15 days history. So that is why at that time it was diagnosed. We just kept a provisional diagnosis of reactive arthritis. We gave anti-inflammatory. The child responded. And till now, the child was doing well as per the history. The child has been under our follow-up since then only. Then this time, the child came to us with a history of this prolonged joint involvement. After initial, ma'am, actually the investigations that he told were the initial investigations where the inflammatory markers were raised. So we started off with steroids and then initially just naproxen was given. We waited for the blood counts and then gradually we added the anti-inflammatory. And when we started tapering the dose of steroids, the child again relapsed. In fact, the child had twice we tried to taper and there was an increase in symptoms. So now we are actually planning for further therapy, biologics or anything else, depending on the affordability.
Okay.
So ma'am, actually just because we made it like a exam situation for him that he will not be provided any investigations or any other prescriptions from ours, he just took the history and did the examination from his end.
No, but the thing is that what you want to say is that from 2019, the child is under regular follow-up under you, isn't it?
2019, after that they came us with this symptoms. There was nothing in between that.
January when the child came to you, started steroids at a dose of 2 milligram per kg, isn't it?
40 mg, ma'am, 40 mg.
Okay, 40 mg. So as
Yes, ma'am.
so in the high CRP and high ESR was in January, isn't it?
Yes, ma'am. Yes, ma'am.
Okay. So the moment you started decreasing steroid, the symptoms again reappeared.
Yes, 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 ma'am.
Now,
Yes.
so now you have to escalate. You have to move on to a higher step. You have to give biologics or
Yes,
something.
yes. Now, ma'am, we are
See,
planning to go into
in a
biologics.
different way. We thought that the child, this CRP-ESR was in 2019. Okay, fine. So you have to escalate.
Yes, ma'am. Yes.
So just discuss about the regime, treatment regime for the sake of residents. And all the participants are requested to put the questions on the chat box.
I think Dr. Priyankar Pal is there, and this case
And there is a question.
belong to, yes, this
Auxiliary
belong to Dr. Priyankar Pal. So
request to Priyanka to comment on
If
also.
you are available, you can give a very brief comment on it, because I saw your posting in the chat box. So please come up and tell something what if they have missed something else. Priyankar.
There is a question why auxiliary, there's a silvery axilla. What does it mean? Someone wrote in the question box.
Most probably
So it is the stria that
stria due to obesity.
has to get. Priyankar, are you there? Priyankar.
Dr. Professor Minal Das has written, is it required to do HLA-B27 assay for female child more than 6 years? More than 6, a male child is required. Any comment over that?
The thing is that, sir, whenever a child comes to you with asymmetrical oligoarticular involvement, it is better to do an HLA-B27. Asymmetrical oligoarticular involvement, we usually go for a HLA-B27.
And
Someone
as
did
you
it
have,
at the time of 2019
and
because they had thought of reactive arthritis, and
yes,
rightly,
then the
when they
previous
think of
working diagnosis of
reactive
reactive
arthritis, you
arthritis.
should do HLA-B27. Yes, sir, you wanted to say something?
And Dr. Priyankar?
Priyankar is just posting in the chat box. Where is he? So, Jigna, that like Dr. Priyankar has just written that the child was on methotrexate from 2008.
আমি একটু বাইরে আছি আসলে
লিখছিস তো, তুই একটু বল তবে
Actually, I am
methotrexate
calling
কি
you.
পাচ্ছিল এত বছর ধরে?
That's why I've kept myself mute.
Priyankar, you want to add something?
Hello.
তুই মিথোট্রেক্সের দিয়ে একটা কমেন্ট লিখেছিস, ওটা নিয়ে বলে দে না কি বলতে চাচ্ছিস।
Okay. So anything else in this case presentation?
Sir, I'm finished actually.
Probably this child will require biologics.
Yes.
Absolutely.
So can we move to the second case?
Dr. Shapun?
Yeah.
There's a question in the chat question answer session. You just see, and like biologics is maybe difficult for the patient. Someone has commented, Dr. Sanj, full name is not given. Subcut methotrexate, interarterial steroid with bridge course steroid may be helpful. No, not in polyarterial
In the
GI.
chat box, are you finding any question? I can't find anything.
See,
In addition, Leflu can be added. Better to
yes,
HLA-B by
leflunomide can
PCR.
be added. If the child is not
Leflunomide can
cannot
be added.
afford, you can start leflunomide. Provided there is no transaminitis, you can start leflunomide, but before that
Leflunomide
you
can be
change,
option.
change to subcut methotrexate, and you can go up to at least 25 milligram, 20 milligram per meter kg per meter square also. Change to subcut, increase the dose, add on leflo.
Ma'am,
Another question,
Ma'am.
how can you monitor the patient during a steroid tapering process to ensure their disease remains under control and to identify any potential complications?
I got it now, because they are posting in the question
answer
answer box.
For monitoring, you need to do a clinical examination and also some basic laboratory investigation. Like you have to see the disease activity, you have to do a JADA scoring, And also you have got to do some basic investigations like your CRP-SR. Every visit that child comes to you, you have got to see the active joint count. Whatever score you use, be it JADA's 10, 27, whatever you use, you have to see the active joint count. Along with that, some inflammatory markers.
Okay, I think Dr. Chopon,
Ma'am?
just thank
Ma'am?
Jigna, want to say something? Just
Yeah, ma'am, one question, like for PG level, what else, because it was a PG level, so that's how, what else, what were the issues with this? Like just for a PG level, what else, where else can this have been improved or
first,
added?
PIPU is stop sharing.
Okay, ma'am.
PG level, the approach of a case is most important. Whether you're able to diagnose or not, that is not a matter, but approach a case should be right way. Okay,
No,
so
ma'am,
that was
if we were just considering the history taking on examination of this particular child only, like,
and
I
if
think
external,
for MSc,
if external allows to see the investigation, then only can see, like especially in cases of neurology, sometimes MRI can be seen and CT they want to see and all, but otherwise investigations are not given, usually not given in the exam.
Yes,
up to examination part is there.
Okay, ma'am. And ma'am, that DD slide I had only kept just for him to understand, so that he just to know for where are the places where this can be involved. But he will ideally not know too much of details
Yes.
of this. So just as a DD for an examinee, like what should he have kept, like all connective tissue disorders in mind? That's where
Yes,
I
Dr.
had
Rakesh
put in
and
this
Dr.
slide.
Suparna, please comment.
Yes, you
It's
can
not that.
keep.
It's
Yeah,
not that.
Rakesh, yes.
It is not that if you get something very typical, you bring something not possible as a DD, you bring it. That should not be, I think. This is a.
Okay.
But if you get something close, always. I think in this patient, polyarticular GI is very, very fine. You can say that I can complete my diagnosis once I get RX. That's it. And if the patient has mass or not, that you can say. It is the clear or inactive or active or something. This is this, I think. I don't think the important, very DD will be important point.
Absolutely. সব সময় যে তোমাকে ডিডি দিতে হবে, that is not important, because this is a very clear cut case. এখানে
Dr. Suparna,
হ্যাঁ,
Dr. Suparna, many non-Bengali residents are there.
So the thing is that, see, this is a clear-cut case of polyarticular GI. Always, every time you do not have to give a DD, Jigna, because this is a very clear-cut case. You can say whether it's active, inactive, all these things, but putting SLE here would be a little difficult. Yes, you, for the sake of argument, you can keep, but it is a little difficult because this is a very prototype typical case.
Okay, ma'am. Okay, thank you, ma'am.
Actually, it was a girl child, and that's why she wanted to point out that SLE should be thought of. But this is again what Jigna pointed out. This is for the postgraduate student, particularly he is of second year PGT MD in ICH. So whatever he has posted is excellent. So we cannot expect anything just like the fellowship in rheumatology or something like that. Okay. So with your permission, can we move to the second case?
Yeah. Give thanks to the presenter and the mentor also.
So can we move to the second case?
Yes.
Presenter, I think Dr. Amrita. Yeah.
Amrita. Yes,
And
Amrita.
Dr. Abhishekta is the mentor.
Abhishekta, you are mentoring?
Yes, good evening, everyone. Thank you so much for letting us participate in this esteemed program at Sandhya Pathshala. I would like to hand over the presentation to Dr. Amrita Ray, who is a second-year pediatric medicine resident in IPGMER. Amrita, please, would you like to proceed? Amrita?
Yes.
Make it full screen.
A very good evening. I am Dr. Amrita Rai, MD PGT, second year of pediatric medicine of IPGMER. My guide being Professor M.K. Das sir. Today I will be presenting the case of a 10 years old female child who was admitted under us on 28th of April 2022 with the chief complaints of fever for 4 days prior to admission, pain and swelling of right ankle joint for 3 days, and reddish rash over bilateral lower extremities for 3 days prior to admission. Fever was high grade with a documented temperature of 104 degrees Fahrenheit. It decreased with medications. There was no history of any cough, cold, breathlessness, no history of convulsion, no history of contact with tuberculosis. Rash was reddish, raised from the surface, fixed rash. Few old lesions were present, which were blackish. It started over bilateral lower extremities and buttocks, and during the course, few were noted over the extensor aspect of the forearms as well. It was non-pruritic in nature. There was no history of bleeding from any site, no history of any photosensitivity. There was pain and swelling over the right ankle joint. With time, it involved left ankle joint, left wrist, and right elbow joints. There was no involvement of any other small joints or axial joints. The arthritis was additive in nature. The patient complained of restriction of movements. Soft tissue swelling developed over scalp and elbow. There was no history of any pain abdomen, reddish urine or oliguria, or periorbital swelling. Coming to the history of past illness, in the remote past, there is no history of any significant medical or surgical illness. There was no history of any previous symptomatic COVID-19 infection in any way. In the recent past, that is in March 2022, the patient was admitted to a local Tier 3 hospital with prolonged fever. There was no history of any rash or arthritis or any other localizing symptoms. She was diagnosed as a case of post-COVID MISC, as the investigations revealed high COVID antibody titers with IgG being more than 100, and on 2D echocardiography, there was mild aneurysm in the right coronary artery with a Z-score of 3.03, and she was adequately treated as per the discharge records. After 3 weeks of asymptomatic period, patient presented to us and was admitted with the chief complaints, which I described earlier, and she was on low dose aspirin. In the family history, none of the family members suffered from known COVID-19 infection during any wave. There was no history of any rheumatic or collagen vascular disease among any family members. Antenatal history was normal. In the immunization history, the patient was immunized up to date as per NIS up to 5 years. The 10-year booster dose was not taken. The patient did not take any optional vaccines. Nutrition history was adequate, and developmental history, all the milestones were achieved at par with age. Now coming to general physical examination. The patient.
Wait. Experts, please ask the questions on the basis of this.
So you have now presented your history.
Yes, sir.
Once you have said about the rash,
Yes,
but
sir.
rash you have not. It is painful. You have to say whether it is painful. Is there any libido-like thing? If there is paniculitis, if there any digital ischemia, if there any signs of peripheral ulcer, have you told that?
No, sir. The rash was painless.
But that you have to please say, because vasculitic rash may be many types. You may not know, isn't it? As you are saying, it's a palpable thing, lower limb thing. So probably you are saying, you are probably pointing something about small vessel vasculitis like.
Yes, sir.
Second thing, you have said additive arthritis, only 3 days.
Yes.
I think additive arthritis is over the span of 6 months. So it's very small time. It is rather, you can say it's probably a case of acute polyarthritis, acute monoarthritis like case with rash, acute monoarthritis only with rash. I think this is the corollary of this case, because then you have to be careful about rash and soft. You have said soft swelling. What is that soft swelling?
So it was soft tissue subcutaneous edema over scalp and elbow.
So you describe that in detail, because soft tissue swelling, if it is cellulitis, if it is something else, or it is the subcutaneous edema. If you say it's subcutaneous edema, it is a telltale sign of vasculitis, some form of vasculitis, usually. So there is a lot of clue in the case that this patient is having some vasculitic rash, subcutaneous edema. Probably we are dealing with some vasculitis. That has to be highlighted, I feel. This is, you have to be careful in describing those points. Madam, if you want to comment anything,
No,
or
okay,
you can
fine.
continue.
So the child is having just acute onset, which I agree with Dr. Rakesh. Should not mention the term additive because just 3 days you cannot call additive. It was basically a polyarticular involvement or monoarticular.
Because 4 joints were involved.
Four joint oligoarticular, basically oligoarticular involvement of the joints, and together with there is some skin rash which is blanchable. You are saying
non-blanchable.
Non-blanchable, whether tender or non-tender, whether any other peripheral ulcers, etc., like Dr. Rakesh has said, and there are no urinary symptoms or no GI
Yes,
symptoms.
ma'am, I mentioned no urinary symptoms.
Okay, fine. Continue.
So what is your differential from your history?
Yes, provisional diagnosis or
So
differential, whatever.
from history or differential diagnosis, where it can be a small vessel vasculitis, the most common being IgA vasculitis, that is henoch-Schönlein purpura, or it can be a case of SLE.
SLE. SLE 3 days only. Madam, only 3 days. The history is just 3 days. So it is something acute, isn't it?
Something acute.
In 3 days, very difficult to comment about SLE, isn't it, Dr. Rakesh? Just
Yes,
3
yes.
days history.
I feel you are right, madam. IgA is definitely IgA vasculitis is one of the PD, but the DD of IgA vasculitis, like your other small vessel vasculitis,
Absolutely.
hypocomplementary vasculitis, that should be probably your more plausible
And
DD.
one more thing with Dr. Kalpana Datta has rightly mentioned, was there any pruritus associated with this rash?
No, ma'am, it was non-pruritic. I
Okay,
mentioned.
so you mentioned it. So
Yes.
basically, you are dealing with a small vessel vasculitis affecting the skin and the joints still now.
Yes, ma'am.
Yes.
Now coming to general physical examination, the patient was alert, conscious, cooperative. Pallor, cyanosis, clubbing, jaundice, edema were absent. Pulse was 100 per minute, normal in volume, character, rhythm, no radioradial or radiofemoral delay. BP was 110/70, which was between 95th to 95 plus 12 percentile, that is stage 1 for this patient. JVP was not raised. There was no sternal tenderness. Facies was normal, no puffiness, no malar rash, no alopecia. Reddish palpable rash were noted over the extensor aspect of bilateral lower limbs and buttocks, and few over extensor aspect of the forearms, which were non-blanching. There was no redness of eye or subconjunctival hemorrhage. Subcutaneous edema was noted over scalp and elbow, and it was tender. Joint examination was suggestive of active arthritis. There was erythema, swelling, warmth, tenderness over bilateral ankle joints, left wrist and right elbow joints, and there was decreased range of movements. Now, anthropometry showed height for age was between 58 to 98 percentile, weight for age was also between 58 to 98 percentile, and weight for height was normal. Hence, the nutritional status of the patient was normal. Coming to systemic examinations, GI examination was done first. It revealed no palatal ulcers, no purpuric spots or mucosal bleeds were noted over the oral mucosa. On inspection, abdomen was normal in shape, umbilicus was normal in position and shape, and no scars were seen. On palpation, there was no organomegaly or palpable mass. Percussion note was tympanitic, including the flanks. Nervous system examination revealed normal higher mental functions. Cranial nerves were normal. Tone power was normal in all the 4 limbs. Reflexes were normal. Plantar was bilateral flexor. There was no cerebellar signs. Gait could not be assessed as the patient was unable to walk. Respiratory system and cardiovascular system examinations revealed bilateral vesicular breath sound was audible. No audible crepitations or wheeze. S1, S2 was audible. no muffling of heart sound, no rub present or no gallop. Hence, summarizing the case, it was
one point I want to say,
yes, sir.
as you basically your history was suggestive of something small vessel vasculitis. Your examination and history should be more stressed on GI system and renal system. You should be asking about any history suggestive of mesenteric ischemia, any history suggestive of abdominal pain, all these things. And renal issue is very, very important here. That has to be stressed properly, both in history and examination, because this is the important organ which is supposed to be involved in this type of cases.
Absolutely. Small vessel vasculitis, we have to keep in mind the kidney and the lungs and the both most important. One more thing is that in maybe I've missed it. In general survey, did you mention anything about pallor?
Yes, ma'am. Pallor was absent.
So why did you, when pallor is absent, why did you go for sternal tenderness? I didn't understand.
Why do you go for sternal tenderness, bony tenderness?
That too also sternal.
Yes.
And another thing, someone asked, Dr. Ahmed asked, could it be a rheumatic fever? Any features of a rheumatic fever?
CVS examination was within normal limits, and
it is not rheumatic arthritis. Could it be a rheumatic arthritis only?
The arthritis was not migratory.
No,
migratory is not a very important thing. Fever and acute arthritis itself may be a DD of ARA, but your rash is not at all fitting.
Absolutely, the rash.
Yes.
And in ARA and in acute rheumatic fever, yes, the joint pain may be so severe that the child becomes bedbound, actually curls up on the bed with the bed sheet. That is the typical posture. Okay.
Yes.
So that should be a DD, but the rash is against going against it. And if you are not getting pallor, why are you looking for bony tenderness?
Fever, arthritis.
Okay, fine. Short history. Okay, fine. Short history. You have
history.
Okay, short history.
No, as he got purpura, he thought it is something like ITP. As you have said, palpable purpura, it won't be ITP. So standard tenderness may not be important here.
It is most probably a vasculitis. So you have mentioned about urinary symptoms.
Yes, ma'am. In the history I mentioned, there was no history of any reddish urine or oliguria.
Okay. And for hypertension, what did you look for in general survey? You looked at the pulses, all 4 limbs.
Yes, ma'am. There was no discrepancy between the pulses in all the 4 limbs.
Okay.
Pulse and blood pressure, very important.
Carotid bruit, etc. Everything you ruled out, isn't it?
Yes.
You haven't mentioned, because if the blood pressure is very high in such a small child, like the kid, most probably kidney is the cause, isn't it?
Yes.
Someone mentioned about leukemia.
No.
The child has got palpable rash. We have to remember that. It is most probably a vasculitic rash.
Moreover, there is no pallor.
Yes.
Leukemia, the most consistent feature is the pallor.
No splenomegaly.
No organomegaly, no lymphadenopathy.
Yeah, that is there, but in few percentage of cases without organomegaly and lymphadenopathy, they might present.
And hypertension.
Yeah, hypertension is there, no pallor is there.
So leukemia, I think, should not come here, because you have to fit everything in one picture. Small vessel vasculitis affecting the skin, causing hypertension. Most probably kidney will also be involved.
It is also involved.
Okay, let us see what she can unfold for us.
So summarizing the case, 10 years old female child born out of non-consanguineous marriage with age-appropriate development and immunization up to date, with a history of MISC KD phenotype in recent past, presented with recent onset high-grade fever, arthritis involving large joints, and palpable purpura mostly involving lower limbs, no history of reddish urine or oliguria or pain abdomen or abnormal bleeding from any site. Examination revealed the presence of active arthritis, palpable purpura, and stage 1 hypertension.
Good.
So can I ask one question? That the child was diagnosed MISC KD 2 weeks back.
In March 2022.
And you examined the child in April.
Yes, ma'am.
Was the child put on any inflammatory medications like steroids or something during this period?
She received steroid for about 2 weeks, and she was on aspirin, low dose aspirin.
Okay. So when the child came to you, steroid had been stopped?
Yes, ma'am.
Fine.
So at this point, our differential diagnosis were SLE and IgA vasculitis or Henoch-Schönlein purpura.
Actually, won't fit here. Some form of small vessel.
And just short history of just 3 days. I agree that sometimes SLE may also present as small vessel vasculitis. We have seen several cases like that, but just a short history of just 3 days.
Yes, ma'am. Points in favor of SLE were 10 years old female child, the age and the gender. Along with that, the presence of hypertension, which may suggest underlying
Okay,
renal
yes.
involvement.
Fine.
Good. That's good.
Okay, fine.
Now moving on to investigations. Urine analysis on admission showed the presence of albumin 2+, and there were RBC about 8 to 10 per high power field. Urine output was about 0.6 ml per kg per hour, and urine culture sensitivity showed no growth. Therefore, the patient had microscopic hematuria with moderate proteinuria.
So renal
Also
involvement is
24
there.
hours urine protein or protein creatinine ratio. We do not go by 1+, 2+. We want to know what was the protein creat ratio.
We've done that. Actually, protein creatinine ratio is not done free of cost in our hospital, and the patient couldn't afford.
24 hours urinary protein.
24 hours urinary protein we've done later.
Oh, later. But when you are getting this type of protein, you should do 24 hours urinary protein. You should do.
So they required for the management.
Well, we have done it in the later part of the presentation. We have mentioned 24-hour urinary protein estimation has been given later on when actually it was performed.
No, the thing is that when you're getting a 2+, our point is that when you're getting a 2+ protein, you should do at that protein, that urine sample only should be sent for 24 hours urine protein. Because a 2+ protein with an active urinary sediment.
This patient is having renal involvement. You are supposed to do it. Otherwise, it's difficult to manage later also.
Okay, sir.
And what about the blood examination?
Yes, ma'am.
Yes, ma'am.
Complete blood counts and ESR revealed a presence of microcytic hypochromic anemia. Platelets were toward the higher side, that is about 5.3 lakh per millimeter cube. The ESR was raised and there was neutrophilic leukocytosis with a TLC
So
of
that
about...
is acute phase reactant.
So may I ask you a question? With an hemoglobin of 7, there was no detectable
9,
pallor.
8.
And you missed it.
7.9.
7.9. There was no pallor on examination.
Some amount of pallor.
There has to be some amount of pallor which must have been missed, isn't
I
it?
think some palmar pallor we should have been there.
7.9.
I think clinically it might be some mild. Mild pallor would be there.
So this patient has all acute phase reactant increase. Polymolecular leukocytosis, thrombocytosis, ESR range. Fine. So
you
it
are
cannot be
dealing with a
leukemia, cannot
vasculitis.
be this thing.
Exactly. This rules out leukemia. You are dealing with a vasculitis, hypertension, active urinary sediment, high inflammatory markers. Most probably a small vessel, not a large vessel, because yes, hypertension is there, but your pulses are all equally palpable. Not a medium vessel, most probably a small vessel affecting the kidney also and the skin. Small vessel raised urea creatinine, yes.
Renal function test revealed elevated urea creatinine. Urea was about 82 and creatinine of 1.1. LFT showed a low normal albumin. Rest of the parameters were within normal limit.
May I add something? With a high creat, urine output of 0.9, you have got to measure urinary creatinine clearance. That you've got to measure and you've got to mention. Okay. Urine output is just normal, isn't it?
Yes.
0.5 and 0.6 and your high creatinine. You've got to mention creatinine clearance here. Okay.
Estimated creatinine clearance.
Yes. There is a formula.
ECRCL.
Yes. You have to tell about it when you're talking about this sort of case.
May I continue?
Yes.
Inflammatory markers were sent, which showed CRP was 250, LDH was 643, ferritin was 842, IL-6 was more than 5,000, and procal was normal. This showed that all the inflammatory markers were raised with a sky-high IL-6. C3C4 ANA and dsDNA were sent. 2D echo revealed no pericarditis or pericardial effusion. All the coronary Z scores were normal. Left ventricular ejection fraction was normal. USG KOB revealed bilateral cortical echogenicity was raised and corticomedullary differentiation was altered. Following these investigations, the patient developed one episode of fresh blood in stool. This was considered as severe GI involvement, and the patient was started on pulse injection methylprednisolone. The C3C4 report came to be normal, ANA was negative, and dsDNA was negative. Hence, our differential of SLE was ruled out. Now the question comes, is it HSP or other vasculitis? There were certain odd points, like there was no pain abdomen, there was presence of persistent high fever at onset, inflammatory markers were high with a sky-high IL-6, and the patient had a background of MISC in the recent past. So, a skin biopsy was done next morning.
No, the patient had GI bleed, some bleed you have told. So, no pain abdomen, that is some abdominal involvement. Then you have documented RBC coming in the urine. So, that is renal involvement and hypertension. So, you cannot say that no involvement like this. Second thing, your inflammatory markers are maybe raised in vasculitis also. It does not require another possibility of MISC to come in the picture to fit it in. This is my point of view, I think.
Absolutely, absolutely. History of MISC may be just coincidental. Yes, there are reports of autoimmune phenomenon occurring post-MISC. There are reports we have seen, isn't it, Dr. Rakesh? We have seen autoimmune phenomenon developing post-COVID. Okay.
It is not easy. It is not easy to equal it.
Exactly.
It may be,
you can correlate those two. Yes.
Yes, yes.
So this is the ideal time when the child presents with such atypical manifestations. The skin biopsy is mandatory because in HSP, you do not need a skin biopsy to do a diagnosis, isn't it?
Yes.
HSP is basically a clinical diagnosis.
Yes.
But these are the times when the child presents with an atypical features. Then these are the times you have to demonstrate whether there is IgA in the skin or not. Biopsy. Okay.
And even the renal involvement is there. You are required to do a renal biopsy.
Yes, also renal biopsy.
And other differential of small vessel vasculitis is also required.
Did it go for the C3 and skin biopsy report? Did you get the result?
Yes, ma'am. Yes, ma'am.
Okay.
I'm sure.
What is the result?
Skin biopsy showed cutaneous small vessel leukocytoclastic vasculitis, and on immunofluorescence, it was negative for IgA. There is this recommendation by the SHARE initiative. They suggest that absence of IgA staining on biopsy does not exclude the diagnosis of IgA vasculitis. But at the same time, other investigations to rule out the other vasculitis should also be done. So at this point, we send ANCA and anti-GBM.
See, may I add something?
Yes, ma'am.
Presence of IgA in skin biopsy has a very high rate of sensitivity and specificity. About, isn't it, Dr. Rakesh, about 96 or 98%?
Yes, yes, yes.
Demonstration
That's
of
why
IgA
they have
in the
classified
skin
IgA vasculitis, separate entity.
That is why it's called IgA vasculitis. And absolutely. So you should have mentioned more about in the DDs, you should elaborate more about small vessel vasculitis, isn't it? In the DDs,
yes.
Which you did not have. Once you got a renal involvement and a GI involvement, your line of thought would be other DDs of small vessel vasculitis.
Typical RAS of small.
Absolutely.
So after this, the patient received 5 days of pulse methylprednisolone and then oral prednisolone at 2 mg per kg per day, and low dose aspirin was continued up till 6 weeks. Amlodipine was used as an antihypertensive. Following this, the patient became afebrile, joint pain and swelling decreased, subcutaneous edema decreased.
So with this GI bleed, you're continuing aspirin?
Ma'am, platelet count was normal, in fact on the higher side.
Actually, mesenteric ischemia should have been ruled out. It is difficult to do investigation in this part of the world, this part of the area, that mesenteric vasculitis or mesenteric ischemia. It is difficult to do this investigation, but it is important point over here also. And you are not ruling that, you are giving aspirin. That is important point.
Did you go a CC? Okay, fine.
So following methylprednisolone, there was a decrease in the TLC count, and there was also a declining trend in the inflammatory markers. In the renal function test, the creatinine showed an increasing trend. The patient developed decreased urine output of about 0.4 ml per kg per hour. She developed puffiness of face and bilateral pedal edema.
Methylprednisolone is only a crisis reliever. Once you are giving methylprednisolone, we should be very serious about what is the exact diagnosis and the therapy regarding and therapy pointing that. That is also important. Methylprednisolone is not just but a crisis reliever. You are just putting up the crisis only. That effort has to be there. You have to do a renal biopsy upfront, I believe.
Sir, renal biopsy has been done.
Absolutely, upfront renal biopsy.
Okay, continue. Investigation.
So on urine dipstick, then there was 3+ proteinuria. Albumin was repeated, which was about 2.8 gram per dl, and cholesterol was 250 milligram per dl. So 24 hours urinary protein was sent. The 24 hours urinary protein was 42 milligram per meter square per hour, which was in the nephrotic range. So the patient was planned for renal biopsy following nephrology consultation after performing appropriate investigations like PT, INR, APTT, appropriate serological examinations like hepatitis B, C, and HIV. Renal biopsy report came, and it was suggestive of crescentic and necrotizing glomerulonephritis with minimal tubulointerstitial chronicity, and there were more than 90% crescents. Immunofluorescence showed quasi-immune glomerulonephritis, and IgA was negative here also. Hence, as IgA was negative, our diagnosis of HSP nephritis or IgA vasculitis was ruled out. Then the following reports were received, where C-ANCA was positive with a titer of 191 units per ml, and P-ANCA and anti-GBM antibodies were negative.
C-ANCA was a immunofluorescence study, and PR3 is the ELISA study. Both are not same.
And nowadays, the recommendation is that you go for a just ANCA study. We do not usually do PR3 now, PR3 or MPO. We go straight for just ANCA, the latest recommendation now. Okay, we do not have to do PR3. Only if you are strongly suspecting post-immune glomerulonephritis and your ANCA is negative, then only you either repeat the ANCA by different study or you go for a PR3 MPO. Otherwise, ANCA is fine enough.
So our diagnosis was, it is a case of rapidly progressive glomerulonephritis due to ANCA-associated crescentic glomerulonephritis with more than 90% crescent. Further investigations were done to rule out other manifestations of ANCA vasculitis that showed X-ray chest and X-ray paranasal sinuses were within normal limit, and HRCT chest was within normal limit.
This is for GPA.
Yes, sir. There are certain landmark trials that have been conducted to establish the treatment of ANCA nephritis. According to those, the main modalities of treatment are steroid along with other immunosuppressant like cyclophosphamide or rituximab for remission induction. So accordingly, we planned to give pulse cyclophosphamide along with prednisolone at the rate 2 milligram per kg per day. Nephrologist was consulted. They advised to start the patient on rituximab instead of cyclophosphamide. Hence, for remission induction, our patient was treated with rituximab at a dose of 375 milligram per meter square weekly for 4 weeks. At 1 year follow-up, the patient is currently asymptomatic with normal renal function parameters. Repeat ANCA titers show declining trend. There is no persistent proteinuria. For maintenance therapy, patient is being given 4 doses of rituximab weekly every 6 months apart and planned to be continued for 2 years. Now the question comes, is it a case of primary ANCA vasculitis? Points against primary ANCA vasculitis were such an early age of presentation. In pediatric population, the reported incidence of ANCA vasculitis is about 0.5 per million children. And the patient had no respiratory involvement, which is usually present in about 80% cases of ANCA vasculitis. So the question remains, is it atypical early presentation of primary ANCA vasculitis unmasked by previous COVID-19 infection and subsequently patient will develop respiratory involvement, or is it a case of secondary ANCA vasculitis temporally associated with COVID-19? This is a case report that reports the incidence of ANCA-associated vasculitis following both COVID-19 infection as well as vaccination. Thank you.
See, it is very difficult, like Dr. Rakesh has said, to relate the two, whether it's due to SARS-CoV or with, as of now, you have got to treat it as a primary ANCA vasculitis, isn't it? So what were the oddities in your case which pointed out a non-HSP variant?
Initially, the patient had no pain abdomen. Later, she developed GI bleed, one episode of GI bleed, but initially there was no pain abdomen and presence of a high fever, persistent high fever at onset.
And hypertension. You do not expect hypertension, isn't it? These were the oddities which went against an IgA nephritis.
May I have some? May I say something?
Please.
Okay. This was the case which was admitted under me coming from Peripheral Medical College with a diagnosis of MISC regarding aspirin, as because the patient had the aneurysm, mild aneurysm in the discharge certificate, and 6 weeks period was not over. That's why low dose aspirin was continued, and there is no contraindication for continuing low dose aspirin when the platelet count is 80,000 or more. Number 2, regarding this fleeting and additive, the standard teaching in acute arthritis, particularly when we teach a patient, when we teach rheumatic fever and the history of large joint swelling one after another, we just ask whether it is fleeting or it is additive. So additive and fleeting, this chronic arthritis, additive terminology should be used. I am in different opinion that during acute evolution of the joint symptomatology, whether one after another the joint is being involved or not, that is very important. That's why this additive term has been used here. I think it may be avoided, but the joints were involved one after another without the improvement of the previous one. That means it was not fleeting. Regarding the EGFR, the chronic kidney disease we must mention EGFR, and for AKI, this renal output of the urine and creatinine level, I think these are enough for AKI description. Regarding skin biopsy is definitely, this HSP is clinical diagnosis, but exclusion of other diagnosis. And skin biopsy very rarely required, but sometimes very helpful. As the expert said, the sensitivity and specificity of skin biopsy is very high. And as the patient had background MISC, and we in this era of post-COVID era, we do not know about the after effect of COVID. So every time I was in a mind that whether this vasculitis was the flare, should I say flare of MISC, or should I say the vasculitis triggered by that? Because the patient had very high fever, which we do not get in cases of HSP, though some systemic symptoms like fever may be there due to that vasculitis and arthritis, but this degree of high fever, persistent, sick child, so it was a bit atypicality in my mind. That's why when we saw the child and this palpable rash, we were in a mind that we should go for this skin biopsy to establish that it is IgA vasculitis. Regarding renal biopsy, yes, in case of always we were in a mind of HSP. Whenever there is palpable purpura, arthritis, pain abdomen, or GI bleeding. Here there was GI bleeding. At that point of time, there was no, and urine examination showed microscopic hematuria. So there was no confusion to say, and stage 1 hypertension, so renal involvement. So we were in a mind that the patient was suffering from IgA vasculitis. But in case of IgA vasculitis, it is not routine to do renal biopsy. So renal biopsy is specific indication for renal biopsy.
Dr. Amrita, please stop sharing.
In HSP is nephrotic presentation or development of AKI. So when the patient developed over the time, only within 7 days, the patient developed this nephrotic range proteinuria and pedal edema, which was not there earlier, and puffiness of face. So we decided to plan for renal biopsy, and the renal biopsy was done. And after that, the everything revealed that it was and at that time we also thought of other small vessel vasculitis when we got a report of IgA negativity in skin biopsy. So ANCA was sent, and the report revealed the whole thing, that it was a case of ANCA vasculitis, which this is the first case which I am dealing in my 30 years experience, that it is not common at all. That's why I did not think of ANCA vasculitis in this child where there is no respiratory involvement. That's all. Dr. Rakesh.
Sir, may I add a point? Yes, Rakesh, you add, then I'll add something.
Thank you, sir. Actually, you are right, sir. ANCA vasculitis is not that common in children. So that's why we do not always think of it. But even then, the immune mediated renal glomerulonephritis or vasculitis, ANCA is still a possibility, because we are in tertiary care center. We get referral patient, so we do it actually. That is my point of saying. And few days earlier only, Dr. Suparna has reviewed the ANCA-associated vasculitis and presented in conference also. She will share her thoughts also.
So may I add a point? There were some oddities in the case which from the very beginning pointed that it could not be an IgA vasculitis. The anemia, the high inflammatory markers, you do not get such high inflammatory markers in a simple case of IgA vasculitis, do you? So these were the pointers which were pointing towards the non-IgA vasculitis. And regarding the creatinine clearance, the question was raised because we had to know how severe was the affection, because you were planning to give cyclophosphamide, isn't it? So before you give cyclophosphamide, you've got to know the creatinine clearance. Otherwise, you cannot give cyclophosphamide with a child with such a high urea and creatinine. And from the very beginning, the high inflammatory markers were very much going against IgA. Because in IgA, we do not get like this. Yes, we get pain abdomen, we get GI bleeding, we get active urinary sediment. Yes, we do get, but such high CRP, such high ESR, ILC is going up to more than 5,000. It's quite unlikely of an IgA vasculitis.
Yes, madam. That's why I think that it is a case of ANCA vasculitis temporally related with post-COVID-19 infection.
Sir, that is a $1 million question, which much more many reports in future will be able to find the link. As of now, we can, because the treatment is same. You have got to give immune suppressants, whether it's post-COVID or whether it's primary. The treatment is more or less the same. You've got to give rituximab.
And the report which was displayed here, that is not case report, that is review article.
Okay.
That is review article. And in most of the cases of ANCA associated post-COVID vasculitis or ANCA was P-ANCA. Here, C-ANCA was less in number in that series, but in our patient, it was C-ANCA.
Yes, young.
And another point that there is one fixed pro forma for renal biopsy in our nephrology department. In that, the ANCA is not included. ANCA is not included, particularly in pediatric case group.
No,
So
absolutely, sir. You're right. There are
we did not.
for renal biopsy in HSP.
Dr. Suparna and Dr. Rakesh, there are questions in the question answer. Can you see and can you highlight that? There are two questions and question answer. Otherwise, I can go to Dr. Suparna can read it.
There are a few questions.
In the question answer session, there are two questions are there.
They have already answered the sternal tenderness to rule out the.
No, not sternal tenderness. One I am going through. It may be variable vessels vasculitis in presence of significant past history. As patient with HSP may develop Behçet's disease. Child needs follow-up both for renal involvement of HSP and also for evolving features of BD. I think that is on the basis of history and all. After exam investigation is clear. Second question.
As per recent classification, variable vasculitis is one possibility, but it is still more rare. So we should think which is commoner to rare. I don't think it is one possibility here. Ancestral vasculitis is a good possibility, definitely.
Okay. Second question is in kidney biopsy, there are so many deposits. And in bracket he has written, I'm not sure was it. AAV is a Pauci immune. And was there any ANCA staining in renal biopsy also?
We do not usually go for ANCA stain in renal biopsy. We see that in the blood.
But one more point I want to say, madam, that renal biopsy is invasive thing. ANCA is a non-invasive thing. So I don't, but even I feel that ANCA should have been sent earlier.
The moment you get the teaching is that what we actually follow is that the moment you get a non-IgA vasculitis, you have to send all your markers.
Okay, yes. Dr. Suparna, if it is ANCA is positive, and then you are not going to do biopsy. You have to do the renal biopsy.
Of course, biopsy you've got to do, madam.
So invasive, whether you do earlier or, but you have to do it.
Biopsy you've got to do.
Yes. Very nice case. Very nice and brain stimulating case.
Answer of that question.
You managed well, so that is a
very brain stimulating case. Very nice case. Very
and you're following the latest protocol also.
Dr. Das is want to answer the question. Yes, sir. Yes, sir.
Answer of that question that.
Yes.
Unmute, Dr. Das. Unmute.
There was IgA negative, but IgG positive 2+, IgM I think 1+ or 2+. So 3+ or more. It is less than 3+. That's why it is Pauci immune, and some were absent, some were present like that. That's why it is possible.
Okay. Thank you.
Thank you, madam.
Dr. Chopin, if there's no more questions, you just wind up.
Okay, and thank you all the presenters like Pillai and Amrita for excellent presentation of the cases. Thanks mentors, Dr. Jigna Bhatia and Dr. Obishikta, and also our expert like Professor Rakesh Mondal and Professor Suparna Guha. I just want to tell just one thing. We are not worried about what is the clinical diagnosis of the case because it is not that we want from the PGTs. Main intention for promoting the Sandhya Pathshala for presenting the cases so that they can present in the examination a flawless one. So by the history part is much more important than the investigations and the final diagnosis. We don't want any diagnosis from the PGTs, but our intention would be that there should be a flawless presentations of their patient. So whatever unusual or cases or the legal cases we are present, we are not interested at all. So that is another, because that for that we have kept a case presentation series in a monthly clinical meeting and all that, and all the hospitals will get that facility. So I will request all to just give emphasis on these case presentations by the PGT so that they can improve their clinical acumen and how they should present the cases flawlessly. So with that, again, thank you all. Thank you, Kalpana Madam, and all those who have joined, particularly Professor N.K. Das, Professor Mihir Sarkar, and obviously Professor Joydev Rai and Priyankar also. Dibyendu has also joined. So we'll wait for the next Sandhya Pathshala next month. So good night.
Thank you, Dr. Suparna. It's a wonderful exercise. We learned a lot. Thank you, Dr. Suparna, Dr. Rakesh, and the presenters and experts also, and the mentors too. They have prepared their PGTs very nicely, and all the points they have taken care of. So thank you, the mentors and all the participants. But participants are not that much interactive. We wanted more interactive sessions from the participants.